The efficacy of transcranial magnetic stimulation, TMS, in the treatment of major depressive disorder, MDD. Depression affects over 280 million people globally, making it a significant cause of distress and disability around the world. While there are many types of depressive disorders, this presentation focuses primarily on major depressive disorder or MDD. Despite available treatments, approximately 50 to 60% of patients don't achieve adequate response from conventional approaches like CBT or medications. This treatment gap has driven the development of innovative interventions like transcranial magnetic stimulation or TMS, a non-invasive brain stimulation technique approved for treatment-resistant depression. Transcranial magnetic stimulation is a non-invasive technique that modulates cortical activity. A time-varying current in the scalp coil generates a brief magnetic field passing through the skull to induce electrical currents in neural tissue up to 2 centimeters deep. The most common clinical form is repetitive TMS, or RTMS, delivering magnetic pulses at specific frequencies. High-frequency stimulation, typically 10 to 20 Hz, increases cortical excitability, while low-frequency stimulation, around 1 Hz, decreases it. TMS works at multiple levels. At the cellular level, induced currents depolarize neurons, triggering action potentials and neurotransmitter release. Repeated stimulation induces neuroplastic changes similar to long-term potentiation and depression, the mechanisms underlying learning and memory. High-frequency RTMS strengthens synaptic connections through LTP-like mechanisms, while low-frequency stimulation weakens them through LTD-like processes. Most interestingly, TMS effects aren't limited solely to the stimulation site. Neuroimaging reveals that magnetic pulses propagate through other connected networks, producing network-level modulation, stimulating the dorsolateral prefrontal cortex changes activity throughout the corticolimbic circuit, including deep regions like the anterior cingulate cortex and amygdala. Some animal studies have also suggested that TMS influences brain-derived neurotrophic factors, or BDNF, crucial for neuroplasticity. Through human translation. We aren't sure exactly how well it translates, so it needs further investigation. Major depressive disorder is characterized by persistent low mood, inability to experience joy from activities typically enjoyed, and cognitive and physical symptoms that significantly impair function. It's a leading cause of disability worldwide. MDD isn't simply a chemical imbalance, but involves a complex dysfunction across multiple neural systems, affecting emotional processing, reward circuits, executive function, and stress response systems. MDD changes many fundamental functions in the body, and this change involves interconnected neurobiological mechanisms. Most prominent is the corticolimbic circuit dysfunction. Neuroimaging consistently shows hyperactivity in the limbic regions, alongside hyperactivity in prefrontal cortex regions, especially the dorsolateral prefrontal cortex. This imbalance reflects impaired top-down emotional regulation, where diminished prefrontal inhibitory control over limbic structures leads to heightened negative emotional processing and rumination. At the neurotransmitter level, MDD involves dysregulation of multiple systems beyond the traditional monoamine hypothesis. Contemporary understanding recognizes glutamide and GABA dysfunction, particularly in the anterior cingulate and prefrontal regions. Structural imaging reveals volumetric reductions in the hippocampus and prefrontal cortex, reflecting stress-related neuronal atrophy. Additionally, HPA axis hyperactivity contributes to chronic cortisol elevation, affecting neural plasticity. The evidence for RTMS efficacy is very extensive. The 2019 network meta-analysis by Woods and colleagues analyzed 113 randomized controlled trials, and bilateral RTMS showed an odds ratio of 4.92 for response compared to sham. Berlin's 2014 meta-analysis of high-frequency RTMS found 29.3% of subjects were responders versus 10.4% receiving sham, yielding an odds ratio of 3.3. A multi-site naturalistic study of pharmacoresistant MDD reported 58% response rate and 37% remission rates during acute treatment. Among 257 patients following long-term, this benefit demonstrated durability well over 12 months, with approximately 2/3 of initial responders maintaining benefit. However, critical evaluation reveals important limitations. Outcomes show substantial heterogeneity across studies due to variable protocols, patient characteristics, and methodology. Many trials have limited sample sizes and short follow-up periods. Treatment parameters also vary wildly, including frequency, intensity, total pulses, and coil positioning methods. RTMS produces antidepressant effects through several concurrent mechanistic pathways. The primary hypothesis centers on restoring corticolimbic balance. In MDD, the left DLPFC shows hyperactivity when deep limbic regions like the subgenial cingulate are hyperactive. High-frequency stimulation to the hypoactive left DLPFC enhances cortical activity, strengthening top-down regulatory control over hyperactive limbic structures. Functional neuroimaging confirms that antidepressant efficacy is predicted by stimulating DLPFC sites, correlated with the subgenial cingulate. TMS modulates multiple neurotransmitter systems. Beyond conventional monoamides, rTMS significantly influences GABA-glutamide balance, and prefrontal rTMS induces dopamine release in striatum and mesolimbic regions, so acute effects similar to D-amphetamine. Successful treatment correlates with an increased serotoninogenic 5-HT2A receptor binding in bilateral DLPFC. The neuroplasticity hypothesis proposes that repeated TMS induces lasting synaptic changes through LTP and LTD mechanisms. Animal research demonstration rTMS improves cell proliferation, enhances hippocampal neurogenesis, and increases BDNF expression. Along with limitations already discussed, there are also significant gaps in knowledge and literature regarding TMS and MDD. Substantial individual variability in treatment responses challenges simple mechanistic models. In large cohorts, roughly 58% achieve response and 37% remission, meaning significant proportions show minimal benefits. This variability suggests baseline patient characteristics moderate TMS effects. However, identifying reliable biomarkers to predict respondents remains crucial. Most mechanistic studies in humans are correlational. Hypothesized causal mechanisms are largely inferred from animal research, and the extent to which findings from rodent TMS studies translate to complex human depression remains uncertain. Genetic polymorphisms influence TMS response, yet a comprehensive understanding of how and why is lacking. Finally, we also need assessment of long-lasting effects and quality of life improvements. These limitations highlight critical research directions. First, biomarker-guided personalized treatment is essential. Identifying baseline neuroimaging or genetic polymorphisms to predict response and enable personalized protocols. Functional connective targeting DLPFC sites anti-correlated with subgenial cingulate is the only prospective validated independent predictor of response. Second, optimizing stimulation parameters requires systematic research. Currently, frequency, the intensity, pulse number, and location remains unclear and heterogeneous across studies. Novel protocols like theta burst stimulation also require rigorous validation. The current evidence suggests accelerated, deep, and synchronized TMS weren't incredibly more effective than sham. Third, establishing causal mechanisms demands multimodal approaches incorporating baseline electrophysiological and neuroimaging evaluations. Additionally, combination approaches with pharmacotherapy show promise. Greater response and remission rates occur when rTMS is delivered with stable medication regimens. Also, long-term studies beyond 12 months are essential to establish durability and determine optimal maintenance strategies. TMS represents a valuable treatment for major depressive disorder, particularly for treatment-resistant patients. Evidence demonstrates meaningful clinical benefits, with 58% response and 37% remission rates in resistant populations. Proposed mechanisms involve corticolimbic rebalancing, enhanced neuroplasticity, and neurotransmitter modulation, provide a coherent framework, though there are still significant gaps remaining in causal understanding. Moving forward, biomarker-guided personalization approach, optimized protocols, and mechanistic research addressing causality will be essential for maximizing TMS effectiveness in treating major depressive disorder. References